This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here, and I'm joined today by our research fellow.
And I'm Dr. Alara. Today we're looking at a fascinating new study from the Journal of Neurosurgical Sciences, 2026, titled Rapid versus Gradual Weaning of External Ventricular Drains in Aneurysmal Subarachnoid Hemorrhage, a systematic review and meta-analysis.
This is a topic that hits home for anyone who spends time in the neuro ICU. We know that aneurysmal subarachnoid hemorrhage, or ASAF, commonly requires external ventricular drain, or EVD, insertion. It's our bread and butter for managing acute hydrocephalus and monitoring intracranial pressure. But Alara, the real headache isn't always putting the drain in, it's deciding how to take it out.
Exactly, Dr. Aris. There has always been this clinical tug-of-war between rapid and gradual weaning. The authors of this paper point out that the effect of these two strategies on key outcomes, specifically infection rates, hospital stay, and the ultimate requirement for a ventriculoperitoneal shunt, or VPS, is not known definitively. This systematic review and meta-analysis aim to compare these strategies using measurable outcomes to give us some clarity.
It's about time. For the residents listening, think about the traditional gradual approach. You're slowly raising the burette height over several days, challenging the arachnoid granulations to take up the CSF load. The theory is that you're training the brain. But the rapid weaning school of thought says, just clamp it and see. If they tolerate it for 24 hours, the EVD comes out.
And the paper really focuses on the trade-offs of those two philosophies. When we look at the study's aim, they were specifically looking at whether one method leads to a higher rate of permanent shunt dependency. Every neurosurgeon wants to avoid a VPS if possible, but we also don't want to fail a wean and have to reinsert an EVD.
Right. Reinsertion is a major risk factor for EVD-related infections. Let's dive into those measurable outcomes the paper mentions. First, the infection rates. In ASAF patients, the longer a drain stays in, the higher the colonization risk. If a gradual wean takes 7 days and a rapid wean takes 2, you'd assume the infection profile looks very different.
That's a key point the meta-analysis addresses. By aggregating the data, they're looking at whether the gradual group's extended dwell time actually translates to more ventriculitis. On the flip side, the study looks at hospital stay, the length of stay, or LOS. If we can safely wean an EVD rapidly, we're potentially moving patients out of the ICU and even out of the hospital much faster.
Which is crucial for hospital resource management and patient rehabilitation. But let's talk about the VPS requirement. That is the hard endpoint that most of us care about. Did the study find that rushing the wean leads to more shunts, or is the training period of a gradual wean just an old neurosurgical myth?
The paper's meta-analysis is designed to answer exactly that. By comparing the requirement for a ventriculoperitoneal shunt across all included studies, they provide a pooled risk ratio. For our residents, remember that requirement for VPS is often the primary failure metric of any weaning protocol. If rapid weaning doesn't increase the VPS rate, then the argument for a prolonged gradual wean starts to lose its footing.
It's interesting because the paper notes that these effects were not known prior to this systematic approach. In our practice, we often rely on the way it's always been done at a specific institution. One chair prefers a 3-day step-down, another prefers a 24-hour clamp trial. This study attempts to move us towards evidence-based neurosurgery.
And it's a rigorous look. By performing a systematic review and meta-analysis, they aren't just looking at one center's experience. They are looking at the global data available up to 2026. They are looking for consistency in how rapid and gradual are even defined, which has historically been a bit of a moving target in the literature.
So if you're a medical student or a junior resident on the wards, what's the takeaway here? You need to look at your ASAF patient and ask, is this EVD still necessary? And if we start the weaning process today, what is the most efficient path to removal that minimizes infection and LOS without landmining them into a permanent shunt?
Exactly. The paper highlights that while EVD insertion is common in ASAF, our exit strategy should be just as standardized as our entry strategy. By focusing on measurable outcomes like VPS requirement and infection rates, this meta-analysis provides the framework for that standardization.
It's a great leap forward for neurocritical care. I think we'll be discussing the implications of this for our own ICU protocols on Monday morning.
Definitely. It's all about balancing the physiological needs of the patient with the risks of an indwelling catheter.
Well, that's all the time we have for today. Thank you for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. We'll see you in the next episode.
Keep those EVDs level and your sutures tight. See you next time.